Hey everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways.
So that's the Airtraq. There are different blade sizes. The sizes are listed on the side. It is a channeled blade that is meant to secure the tube during your visualization. The tube will then slide through it. There are some important remembering things with this. Is first of all, if you put that tube too far distal the end of there, it's going to obscure your view and then be very hard to push through into the cords. It'll go too far down. It needs to be lubed. The tube will be tight.
Here, we'll just use a smaller tube for now, just as an example. So to Caleb's point, yeah, if you push the tube down too far, you're going to get it in the right bottom corner of your screen, which is a little bit hard to see, obviously, through the camera. The other thing that I see people do wrong all the time is they put the camera on and then they put the blade in, and they're like, why is it so dark? Why is it so dark? And it's because you didn't turn on this little light right here, which is going to light up the end of the laryngoscope blade.
And heat the tip, which is an important fact that you need to start
fogging.
that early to get it to heat up before you make your breach.
Here, you want to try a correctly sized tube?
Yeah.
Now that there's been juice put on it. There you go.
This is not meant to be used with a stylet. So the channel is what is supposed to be acting as your former. And then when you strip it away, you got to be careful that you don't pull the tube back out. You just pull the blade away.
And when a lot of people want to go to use this, one of the easiest ways they teach is actually just to go parallel, and then as you just tilt back, and then right there it is.
Look at that.
So it's easy view. You can see.
Take a picture.
Take a picture if you tap it. Push your tube. If you're in too deep, you just pull back. There's my tube. I see the passage, and then the way we were always trained was you pop this out of the side, hold it in the corner of their mouth to come out. And then one of the things that we didn't discuss, whether it is either DL, VL, whatever you're doing, is securing your tube. So in making sure that you're going to hold on to that throughout this process, whether you're doing video laryngoscope or direct laryngoscopy, you want to make sure that you are holding onto the tube, securing it with a commercial device, and then before Caleb would put that bag on, we would put end title. We would put end title on this patient and secure it. The other factor in any intubation is anytime we go to move this patient, we should be looking at lung sounds, our end title, to see, did we lose our tube? Because that could happen. We're in the business of moving people. And to Dr. Hill's point, it's really easy that now that I've placed that tube, that I can reinsert my video laryngoscope in, take a look, confirm, hey, my tube's still in the right place, everything's still good.
And if it's in a good spot and you decide that you need a bigger tube, or Dr. Hill in the ER, he can use his bougie and do a tube exchange through it, and it works really well.
Yes, and the other things with Airtraq too, so there's 4 different blade sizes. 2 are typically pediatric, 2 are adult. Our agency uses this, and then there's some other options. You can set it up for your agency. You can record the entire intubation. You can touch the screen to take a picture of it. That's what we do. You can actually upload it into your EPCR to say, hey, this is when the intubation was performed. It timestamps it, shows a picture. Very good proof for us. It has pediatric mode. So if you have a pediatric patient, it changes the view of the cords and the brightness that you're going to see the cords, and then you can also rotate the screen. So
that's what I was
in one of Caleb's scenarios. If you have that patient that's trapped in a car, and I need to do some type of
intubation.
Yeah, if you're doing a reverse intubation, that's why I do like this product. And it's nice that all you have to do is change the lower unit, whether I'm going to intubate a 3-year-old or a 30-year-old. All I'm doing is changing a blade and, tapping a button that says now you're in pediatric mode to see some of the differences.
Like everything, there are downfalls to the 100%. Airtraq. The biggest one being that you're not holding it correctly. Arrow to arrow is where you want to be. Snap on, make sure you turn your light on. If you're holding it like a laryngoscope and you do any sort of upward motion, you're going to pop the camera off. And it happens all the time. And then people are, oh, that's Airtraq, it really is not good. It goes back to training. There's actually spots here built for your 3 fingers and channel for your thumb. and that is all you should be using with this. The patient does not need to be ramped for this. This is great for your traumatic injuries, spinal restrictions. You just, like he said, you start in low to the chest, move forward. This is all you should be doing. And if I'm going like this or if it pops it up, you're not doing it right.
Yep.
You're doing it wrong, man.
The other point I wanted to make here is this is what we are.
Oh, yeah, there's several different kinds.
There's a bunch of different kinds, right?
Yes.
This is what we're supplying today, all right?
And some of our squads still have the King.
King Vision.
King Vision is another one that's out there. There's the UE scope.
McGrath. There's
McGrath.
slide scope.
Physio Control.
slide
Striker
scope.
had a product.
It's McGrath. Yeah.
McGrath.
Yeah. But yeah, there's a bunch of different kinds, and fundamentally, there's little tiny differences between all of them, and you just have to know your device. We talked about, we said this multiple times, knowing your
Talk about that.
knowing your tool.
Yeah.
A charged Airtraq is good for over 200 minutes of use, so it's not like should be looked at during your squad checks for sure. But if the camera fails, the blades do come with an eyepiece. I think that's what you're showing.
Yep.
Yes. Yeah, actually, so if your camera did die, you can actually still turn on the distal light, and then you can actually still feed a tube through here, look actually down through this device, and still see the cords.
Which is all the camera really does.
Which is all the camera really does, but it actually provides you with another backup for this device.
Airtraq can also wirelessly Bluetooth sync to your iPads, your phones. We've actually have it set up in our squad, and my guys might not even know it, but you can, as soon as you turn the blade on, it'll sync to the iPad, and you could actually sit there and watch the iPad during your intubation attempt instead of the little camera. And it works really well because I can put that iPad anywhere I'm comfortable and do the attempt.
You get a bigger view.
Yeah, much bigger view.
You know, one of the other things too that when we were playing with the King Vision so much, a lot of times I actually, if you had a very difficult intubation you looked, sometimes I actually used the King Vision in the bougie, pulled this out, then actually introduced my tube, and went back into the double take with this.
Look,
And
man,
it
I
was
said it
fast.
100 times, once you get through NREMT and pass your test, there's no cheating. Like,
No.
as long as you're working within protocol, there's no cheating, so make it work. There's a great YouTube video out there called Do It for Drew. I don't know if anybody's ever heard of it or seen it, but it was a
Sadly,
private
yes.
ambulance company that was doing a transport with a child who was intubated, and they keep getting DSATs, and they're doing everything they can to work the case. So it ended up being that the kid was intubated esophageally, and they just were not getting, Drew ended up dying. So it's a recreation, a reenactment of the scenario that happened, but it's the family kind of put that together afterwards as an awareness. And if you haven't seen the video, it gives me goosebumps. But we play it every year at the class. Do it for Drew. It's worth it.
Yeah.
It's just a heads up on don't just pay attention to your equipment. Treat your patient.
Watch your patient, reassess your patient.
Yeah.
Yeah.
And again, this is the patient you trend, reassess, because things can get dislodged, things can happen.
If you're a paramedic or on a critical care and you're transporting with a vent and things don't make sense, disconnect your vent. Your vent might
Absolutely.
have broken and failed. And
Generally,
always-
this gives, you can feel it. You understand it.
and you can feel resistance.
Yeah.
Like maybe all of a sudden I popped a bleb and now I have
A pneumo.
And it's really hard to bag. Oh, I'm going to relist it. Oh, I have lack of air sounds. I'm going to needle the chest and probably end up being diverted, which has happened to me where I've had to put a chest tube in a patient that was getting transferred as they drove past my ER.
Also, it is in our protocol to consider and place, if you have a chance, a C-collar after you've intubated. Anybody you've intubated, regardless of trauma or not. And I think that's a great way to keep the tube in position.
Any advanced
Secure.
airway. It doesn't
Any
have to be
advanced,
it doesn't have to be an endotracheal tube, but anything to keep their head from rolling around.
And it makes sense. It makes a lot of sense.
Absolutely.